everyone, I am Dr. Sana Ansari. Welcome back to my channel. Today we are going to learn about the most common organisms causing vaginal infections: vulvovaginal candidiasis, trichomoniasis, and bacterial vaginosis. So let's start one by one. First, coming to bacterial vaginosis, what is happening is there is replacement of normal bacterial flora to anaerobic bacteria, commonly Gardnerella vaginalis, Mobiluncus, and Mycoplasma hominis. This is not a sexually transmitted infection, but yes, sexual activity does increases the risk of bacterial vaginosis. Now, some of the common risk factors include multiple sexual partner or new sexual partner, if there's vaginal douching, smoking, or there's lack of condom use. Now, first coming on to the clinical features. Remember, most of the bacterial vaginosis, they are asymptomatic. If there are symptoms, it usually includes grayish white vaginal discharge or there is a fishy odor. There is no signs and symptoms of inflammation. So this is how they usually frame the question. A sexually active female with grayish white vaginal discharge and a fishy odor, and they'll ask about the diagnosis. Now, based on this Amsel's criteria, we can diagnose bacterial vaginosis. 3 out of these 4 criteria needs to be fulfilled for it to be called a bacterial vaginosis. If there is thin homogeneous discharge, if the pH is more than 4.5, this is very important. If there is a positive whiff test or clue cells are seen on microscopy. These are the 4 criteria. Now, the complications usually include increased risk of infection, which can be pelvic infection, pelvic inflammatory disease, STIs, including HIV. During pregnancy, if you catch this infection, there is risk of preterm birth, miscarriage, and postpartum endometritis. Now, coming to treatment. The treatment of choice is metronidazole 400 milligrams twice a day for 5 to 7 days. This is safe in pregnancy also. The alternatives include either single dose 2 gram of metronidazole, tinidazole 2 gram single dose, or even clindamycin 300 milligrams twice a day for 7 days. You can even give intravaginal metronidazole or clindamycin. So the questions usually come about the treatment of bacterial vaginosis, and any of these options are listed and you have to choose among them. Now coming on to the next vaginal infection, which is vulvovaginal candidiasis. It's a fungal infection. Most common organism involved is Candida albicans. The non-albicans species are azole resistant and it is not an STI. Now the risk factors usually include any immunocompromised state like pregnancy, diabetes, or if there is recent antibiotic use, or if the patient is on OCPs, if there is high estrogen exposure. Now, the clinical features usually include itching and thick white curdy discharge. If there is intense itching, the patients usually present with vulval erythema, and the vaginal pH is usually normal, which in case of bacterial vaginosis was more than 4.5. Now, diagnosis of vulvovaginal candidiasis, this is clinical, but if it is recurrent or severe, we usually take a high vaginal swab for microscopy and culture to confirm. Now, the treatment includes azoles. That can be topical azoles, which are given in pregnancy, and if the patient is not pregnant, then you can give fluconazole, which is 150 milligrams single dose. Now, if the patient has come with severe symptoms, like if there's severe excoriation, severe erythema, then you can give 2 doses of fluconazole on day 1 and day 4, 150 milligrams. If there is recurrent vaginal infection, then you have to give a long-term course. Fluconazole 150 milligrams, 3 doses at 72 hours gap, followed by a weekly maintenance dose for 6 months. If the patient is azole resistant on culture sensitivity report, then alternatives include nystatin, amphotericin B, pessaries. Now, the question usually comes in the form of the treatment of choice. If the patient is azole resistant, what all can be given? As I told before, if patient has vaginal candidiasis and she is pregnant, then only topical forms are given. Oral forms are contraindicated. Now, the next organism is Trichomonas vaginalis. They usually give a picture of it. It's a flagellated protozoan parasite, and out of the 3 vaginal infections, this one is a sexually transmitted infection. Now, coming on to the clinical features, There is frothy yellow-green vaginal discharge. Now, this is typical for trichomoniasis. Remember, you have grayish discharge in case of bacterial vaginosis and curdy white discharge in case of candidiasis. There is vulval itching, dysuria, dyspareunia, and you typically get a strawberry cervix. Now, for the diagnosis, this is somewhat similar to chlamydia and gonorrhea. Nucleic acid amplification test is the most sensitive. We take vaginal swab in women, and in men, we take urine or urethral swab. Now, the treatment is similar to bacterial vaginosis. Metronidazole 400 milligrams BD for 5 to 7 days, or single stat dose of 2 grams. It is safe in pregnant patients, but always avoid alcohol if you are giving metronidazole during and 48 hours after the metronidazole therapy. Since it's an STI, we treat the sexual partners and we advise for abstinence until the treatment is complete. Now let's revise the important points for each of the vaginal infection. Bacterial vaginosis, the pH is more than 4.5, clue cells, and there is a fishy odor. Also go through the picture of clue cells. That's also sometimes given in the questions. Vulvovaginal candidiasis, there is normal pH, there is curdy white discharge, and there is intense itching. And in trichomoniasis, there is frothy discharge, strawberry cervix, and it's a sexually transmitted infection. Some more important points: bacterial vaginosis is not an STI. What are actually clue cells? They are epithelial cells coated with bacteria. This is also one of commonly asked questions. Fluconazole is contraindicated in pregnancy. Nucleic acid amplification test is most sensitive for trichomoniasis, and we do require partner treatment in case of trichomoniasis. Now let's practice some questions. Which organism causes bacterial vaginosis most commonly? This is Gardnerella vaginalis. What is the most sensitive diagnostic test for trichomonas? A is microscopy, B culture, C is nucleic acid amplification test, D is gram stain. So the answer is C, nucleic acid amplification testing. So this was all about today's class. If you have any doubt, let me know in the comments. Thank you.